For this technique you will need 50mm zinc oxide tape and 50mm elastic adhesive bandage, adhesive spray, heel and lace pads or Vaseline or both, appropriate padding if needed, and a pair of taping scissors. We must make sure that the area to be taped is clean and not too hairy, as this can impede the effectiveness of the tape. Wash and shave the area if necessary. If appropriate, use a hypoallergenic balm such as Comfeel or Underwrap. Some tapers will advocate the use of adhesive spray prior to underwrapping the area. Personally, I don't do this, as it can make it difficult to remove the underwrap afterwards. I do use adhesive spray when I'm not using underwrap. Tape should ideally be placed directly on the skin for maximum contact, especially the anchors. Hypoallergenic balms usually leave a fine film over the skin, which in itself may assist adhesion of the tape and may negate the need for adhesive spray. A very important part of preparation is having everything you need close to hand so you're not searching in bags or boxes. Ask the patient to sit with their foot and lower part of the calf off the end of the plinth. Always make sure the plinth is at a good working height for you. Start with the foot and ankle in a normal position, as though the patient were standing, and don't place too much dorsi or plantar flexion or too much inversion-eversion. This is simple, just ask them to hold the foot in the position you want. Why do we tape the ankle in this position? Well, this is the normal standing position, and if we tape the ankle as it normally lies when seated, plantar flexed, it will be uncomfortable for the patient when they stand and weight bear, and the emphasis of the technique may be lost. Apply the hypoallergenic balm, underwrap or adhesive spray as applicable to the person being taped. Make sure that when you are applying balm or adhesive spray that you are in a well ventilated room. Care should always be used when using solvents, as inhalation may cause nausea and giddiness. Prolonged use of solvents may lead to other health problems, so always read the safety instructions and heed the warnings. Here I'm using adhesive spray over the area to be taped. First we apply our anchors. These are normally placed above and below the area to be taped, and as the name implies, these provide points on which to anchor the tape. You may want to consider some extra adhesive for these points. Anchors can be zinc oxide or elastic adhesive bandage. Here I'm using zinc oxide. When applying your anchors, make sure that they follow the natural contours of the area being taped. The lower calf, for example, is conical in shape, not cylindrical. If you try to go around the calf as though it were cylindrical, you will get skirting of the tape, and this can rub against the skin and lead to abrasions. Care must be taken when applying tape over tendons or areas that crease, as it can cause friction and also lead to abrasions. In these regions, we would use lace or heel pads or Vaseline or both. Do not place your anchor too tightly when encircling a limb. When placing more than one piece of tape, you should overlap the previous piece by at least half. From here on, any tape applied should be used to support the injured area. Stirrups will assist in stabilizing the talocrural and subtalar joints and assisting supporting the injured ligaments. As we are looking to support the lateral side, we start medially, going over the medial malleolus, looping under the calcaneum, and will slightly pull up on the lateral side to emphasize the support over the lateral malleolus to the anchor point. Take care here not to pull too tightly, as this can be very uncomfortable when the patient stands up. One or more stirrups can be applied dependent on the size of the tape used and the size of the patient's foot. These two particular techniques, anchors and stirrups, are pretty much what most tapers will agree on. The next steps depend more or less on the extent of the injury, the patient's personal preference, and the taper's personal preference. Padding is usually used on acute injuries. Cut a horseshoe or a J-shape out of padding material and place it around the lateral malleolus. This will add compression to the area being taped and act as a pressure attenuator. For the purposes of this demonstration, I'm going to use padding. The decision to use padding or not is made on a case-by-case basis. Locks are designed to add extra support to the ankle. Although there is little evidence to support this, the support to the anterior talofibular region is thought to come from restricting movement of the calcaneum at the subtalar joint, affecting inversion and eversion. You can apply locks to both sides in one unbroken movement of tape. However, I prefer to use two pieces of tape, as I feel this gives me greater control of the amount of restriction I give to either side of the calcaneum. You can see the restriction of movement is produced by producing a sling that holds the calcaneum in place and restricts the pronation and supination at the subtalar joint. We start at the anchor point either medially or laterally. I like to start medially, as it's the lateral side we're trying to support. We pull the tape down at an oblique angle. I usually use the malleolus as a target to aim for, carefully winding behind the Achilles tendon, wrapping the tape under the calcaneum and pulling up on the lateral side. Here we can either go straight up over the malleolus to the anchor point or back across at an oblique angle to where you started from. I like to go back to where I started from, as the tape will then cross the injury site and support it from overstraining. We simply reverse this application for the medial lock. You can add several locks until the patient feels supported. For added support of the anterior talofibular ligament region, we can add a sling that starts laterally above the malleolus, using the stirrup or lock as an anchor point, passing obliquely across the ankle, passing under the plantar surface of the foot, and pulling up laterally across the injury site. Here you have to follow the natural line of the tape and the foot, which will take the tape across the opposite side and to the stirrup or lock as an anchor. Closing is not always necessary, as the bulk of the support work has already been done. I use it for extra support if needed, to decrease the chances of skin abrasion and to hold the loose ends of the zinc oxide tape from pulling off. You can use zinc oxide or elastic adhesive bandage for closing. This will depend on the amount of extra support you're trying to achieve. Here I'm using a figure of 8 technique using an elastic adhesive bandage. There are several variations on this theme, many of which are shown in the book that accompanies this DVD. Don't forget to ask the patient how the tape feels and get them to test it by performing exercise with it on. You must make sure that none of your taping techniques compromise blood circulation or nerve supply. Make sure that the patient can function adequately with the tape on, and be prepared to adjust the technique to suit the patient.